Hello everyone. Good morning, afternoon, or evening, depending from where you're watching us today. I'm delighted to speak to you today and grateful to Richard, UK Cape, and Interprofessional.Global for the opportunity. Allow me to begin with a few slides about me so you can get a sense of the context within which I operate and from which I draw my inspiration. First, I'm here as a board member of the UK Centre for the Advancement of Interprofessional Education, a centre which I hope needs little introduction among those joining us today. I am also here as the Editor-in-Chief of the Journal of Interprofessional Care, a journal that has grown and is growing with all of your support over the past few years, with currently an impact factor of just over 2.3, currently processing close to or over, in fact, 1,000 manuscripts per year, a journal which has gradually found its way into many policy documents and into the dossiers of a number of policy advocates across our world. I do, of course, have a day job as a senior researcher at King's College London. King's has a number of accolades relevant for this talk is that it claims to be the largest provider of health professional education in Europe, which means that we are rather busy, but also that we have quite a bit of experience and expertise to share. I do like to begin my talks, as some of you may know, with a reminder of why we're here, and it is to improve quality of healthcare, strengthen health systems, improve patient safety. This is but one unfortunate example from the mainstream UK media, and it's unfortunately not an isolated incident. In fact, recent analysis from the UK of over 700 prevention of future death reports from coroners has concluded that missed, delayed, uncoordinated care was the most commonly raised concern. This is, of course, not news. We've known that for a while. And in the UK, it has again been brought to sharp focus by those in the UK would know the Ockenden report, which looked into maternity incidences in the UK, where again, unfortunately, poor teamwork contributed to a number of negative, unfortunate, unnecessary negative outcomes from mothers and women and families. It is worth pointing out, for the avoidance of any doubt, that teamwork isn't only a benefit for patients and service users, but also importantly for staff. And I'd like to use this example as one of the few pieces of research that has linked the two together quite clearly. An analysis of over 60,000 employees from the National Health Service in England, showing positive associations between teamwork, job satisfaction for staff with work engagement, strengthening intention to remain, directly linked with patient satisfaction. So the saying that teamwork is not only good for patients but is also good for staff seems to hold. Given so much growing evidence, I often find myself asking, how many patients must die? How many staff must experience burnout before we start to listen to their calls for greater collaborative working in healthcare? The answer, of course, eludes me, or as someone else has said, is blowing in the wind. The World Health Organization has certainly been a strong advocate for interprofessional education and collaborative practice for over a decade, and this is the figure that I hope many of you know, but it's still worth reminding. I find this figure especially useful in pointing all the different levels at which the work that we do as interprofessional scholars can make an impact through education, through practice, through research across levels. And in fact, our body of work has grown significantly, which is something that I can attest to as the editor of one of the journals that publishes this kind of work. The work that we do, that the interprofessional community does, is not only growing in volume, but is also gradually being consolidated into a distinct field of study, a field of study I previously called interprofessional science, a field of study devoted to advancing pedagogies, applied processes, and research methods to promote interprofessional collaborative approaches in health and social care, education, practice, and research. There are so many streams of activity in what we do, all of which impacted significantly by the COVID-19 pandemic, and any of which could serve as a focus for a talk on this particular topic. Commentators across the world, many of whom are with us today, have concluded that the work of interprofessional scholars in education, in practice, and in research has helped maintain our health systems, has helped build in resilience in what we do, and is helping taking us through during this still uncertain peri-pandemic period, moving on gradually into the post-pandemic era. Recently, with a fellow journal editorial board colleague, who many of you know, we wrote this editorial in an attempt to forecast interprofessional education and collaborative practice. Neither Jill nor I have a magic crystal ball, so our predictions are based not on visions but rather on evidence and the collective experience of our community. For the details of our predictions, I must refer you to our article, which is available online on the Journal of Interprofessional Care, current issue. Here, I will touch on just 4 key points. First, a dystopian view relates to the fragile penetrance of IPE into mainstream health professions education. While we may argue the popularity of IPE is currently on the rise in many countries, we caution that sustainability is not always thought through for the long run. It's worth reminding that financial support can be removed as quickly as it is introduced. Second, when riding a popularity wave for interprofessional education, we run the risk of going too quickly, perhaps taking a superficial approach to IPE that focuses too narrowly on traditional and rigid definitions of teams and teamwork, rather than taking an approach that in fact enables students to observe, discuss, and participate in the complexity of practice as it is enacted in their particular context. Third, we see promising signs that high-value care, and indeed high-value education, informed by evidence and experience, is making a strong comeback. While this may also be another trend that may wane in time, the utopian within us expects this to be embedded in health professions curricula for some time to come now. Finally, a view that may be either utopian or dystopian depending on context. At least in some countries, we are already seeing students needing to work in new kinds of interprofessional teams, where rules and norms over professional jurisdiction, roles and hierarchy can be quite dynamic. We may well have to prepare them to engage in a process of reprofessionalization, needing to re-establish their place and professional and interprofessional identities within new kinds of teams. I will close my presentation with some provisional findings from a global survey run during the past 2 years, seeking views on the impact of the COVID-19 pandemic on interprofessional education and collaborative practice. For context, the survey captured views from people at all levels of our community, from students to university deans, and across different continents, as you can see on this slide. You will have to wait for the paper to come out to see the detail, but here I point to 5 main findings drawn from the qualitative responses to the survey. It will come as no surprise that digitalization of interprofessional education and of collaborative practice was high among our respondents' concerns. They noted an abrupt and forced shift to virtual approaches in education and practice, often with unequal provision of resources, leading to perceived lack of parity and exposure. Technology adoption was not without its challenges, and the issue of digital literacy among clinicians and educators was also raised often. Experiencing significant disruption during the pandemic is also not a surprising finding, but instances of deprioritization of IP were rather worrying to see. While on the one hand, respondents noted a rise in interprofessional spirit, with interprofessional collaboration valued as a driver for pandemic recovery, IP was sometimes seen as the first provision to be cut in the context of budget and other restrictions. Finally, there are both opportunities and challenges with regard to interprofessional education and collaborative practice research and evaluation. There are opportunities to research new kinds of pedagogies, ways of delivering care, and methods for such research, as there are challenges of gaining funding and conducting in-person fieldwork in the more traditional way. There are, of course, many papers that have been and continue to be published in this space, which continues to remain dynamic, provided some food for thought, and opened up a space for discussion and debate among our community.